organizing committee for this conference, and thanks to the scientific committee for inviting me for this presentation. Actually, my presentation is going to take the history of introducing child mental health as an independent scientific and academic subject for the first time in Kurdistan. And that's right, it will include, to a large extent, it is going to include the studies and the clinical work with children. But to make a long story short, when we're speaking about child mental health, we have to remember the definition of health generally that's introduced and updated by the WHO. Health is, accordingly, a physical, mental, and social well-being, and not merely the absence of disease or infirmity. Child mental health is really considered as an indicator of development and modernization in any society. Why? Because it includes the following very important scientific fields: child and adolescent psychiatry as an independent specialty, actually, not subspecialty to psychiatry or pediatrics. And that's the Swedish model which I have learned and which I have introduced in Kurdistan. Second, it is depending on pedagogy that's uprising for the child, and it includes clinical psychology, which is lacking actually in Kurdistan. But we have just started to build up capacity building, and we have sufficient cadre in the work, at least. It includes parental and family-related psychiatry. It has to work with social services and special care, particularly for children with special needs. And it includes, to some extent, maternal and child mental care system, and a school mental health system as well. Well, child and adolescent psychiatry, if we speak about the abnormalities included in child mental health, then it is a multidisciplinary specialty. It has to have at least 3 similarly important competences, in order to call it child psychiatry. It must have social workers educated and trained as a member, very important member of the team. It has to have a specialist in child and adolescent psychiatry as a doctor, educated in child psychiatry, and it has to contain a clinical psychologist. This will form a multidisciplinary team which must be present in order to work with the diseases of mental health in children. Well, all started actually here, on the border of Iraq and Turkey in 1991, when the mass escape tragedy resulted in thousands of people fled from the Iraqi army, collected on the border between Iraq and Turkey, and hindered by the Turkish army to enter into Turkey. I was there and interviewed children about their feelings, their thoughts, their memories, and their experiences generally during the mass escape tragedy. 2 months after the disaster, those interviewed children reported these post-traumatic stress symptoms. Not every symptom is related to PTSD, post-traumatic stress disorder. but they are stress-related, child-specific symptoms which results from overwhelming stress. 2 months after the disaster, there was very high frequency of these symptoms among children. 2 months later, that is 4 months after the disaster, when children were returned with their families into the home regions, all the symptoms diminished, both among PTSD patients and the non-specific symptomatology. 1 year later, PTSD symptoms returned to occur, to increase among those PTSD cases, and it remains very high among those children, while the non-specific stress symptoms continue to decrease. Well, those children who develop PTSD in the mass-escape tragedy include only 20% of interviewed children. And it is very low frequency, actually, if you compare it with similar catastrophes. For example, a mass escape in the south of Lebanon in 1983, fleeing from the attack of Israel, more than 80% of their children and adolescents developed PTSD. Okay, why the frequency of PTSD was so low among children of Kurdistan? We had hypotheses. The only cases with PTSD had lost their fathers before the disaster. Okay? Is the presence of the father in the family a protecting factor? It was our first hypothesis. You see, we developed culture-related hypotheses. In the families, there were extended families or the relatives collected together when they started the escape. And the family structure was very clear. The definition of the duties in the family were well defined. Even the children had their functions and their duties according to the age and gender and developmental level, of course. So you see, the girls followed the mothers in taking the responsibilities, while the boys followed the fathers in taking the duties. This gave the children a sense of coherence as Antonovsky developed the psychogenesis theory. I mean that those children had meaningful activity, feeling control over the things they are doing, and understanding what they are doing. These three components included in the sense of coherence. Well, to examine the presence and absence of the parents in relation to mental health problems, we examined interviewed children, orphans who were living in the traditional foster care in Sulaimania and in Duru, and compared them with those children, orphans, who were living in the orphanages. 1 year later, you can see the red line is representing children who were living in the foster families. Their symptoms decreased very significantly, while those who were living in the orphanages, their behavior problems decreased. May I continue? Are you hearing me?
Yes.
That's good. Well, this was a point that gave us an indication that both parents are similarly important in order to protect children from developing mental health problems. Okay, now it is the time to examine the family structure. How can a family system be protective or vulnerability factor for children to develop mental problems? In our society, as you know, there are all possibilities for examination of child mental health. it was easy to identify those survivors who had no family structure, and you knew who they are. Those children who survived Anfal were gathered in two collections, one of them in Sulaimaniya region in Kalar, which was called Sumud, and one of them near Arbil, that was called Bahrikir or Tajnikan. I was there and interviewed the older child in the family and the caregiver in the same family in order to see how they have survived the Anfal operation. Because you know, the Anfal resulted in destruction of the family totally. So there was no family structure remaining for those children who survived the Anfal. And you see directly here how they have survived. The red color represents the children, and the blue color is the caregivers. You see, children, generally speaking, develop PTSD more than adults. And females, especially girls, develop PTSD more than males, more than reunited fathers. Generally, more than 8% of our children had fulfilled the criteria of PTSD. Then we'll compare children of Kurdistan in the book with children from Kurdistan who were refugees in the city of Uppsala in Sweden, where I was working as child psychiatrist. And you can see here, generally, the behavioral symptoms among children of Kurdistan was higher, showed higher frequencies than those children who were living in Sweden, except delinquency. Delinquency problems were higher among children in Sweden than those in Kurdistan. It may have an explanation, and you can tell me that. This research between 1991 to 2001, 10 years research in Kurdistan for child mental health, resulted in establishment of the Department of Child Mental Health at the College of Medicine, University of Duhok in 2001. That unit's function was for delivering of education at 3 levels. Postgraduate education, to offer high diploma that was equal to master degree to the pediatricians. And then an obligatory course of child mental health to the 5th year medical students, making the University of Duhok the first in the Middle East having this course obligatory for a subject like child psychiatry as an independent specialty. The awareness of people during these 10 years of research and the needs were there to develop clinical units. Mental Health Center developed as a clinical and training center in 2004, and it is now transferred to the governmental. Then we looked and observed that the government and the state in Kurdistan is not taking the child mental health as its first priority. As usual, children come last, and especially children with special needs or with mental problems. That was why we started development of a semi-private, that is self-sufficient center for prevention and treatment of child mental health problems. And the aim is to develop a healthy personality. This is the figure of child mental health. It was a project, collaborating project between Uppsala University in Sweden and Duke University. And this was the mental health center, which is currently under the governmental control, and this is the mental health house. We have been working with the first stage in 3 years now, and we have 2 departments, a child psychiatric outpatient and the development department program for children. And just now, we have started building up stage 2 of the mental health house. If we will speak about child mental health now, in the current situation, we can see when Daesh occupied Mosul and Sinjar. In 2014, within 2 months after the attack of Daesh on Sinjar, the population in the Hope doubled because of the mass escape of the IDPs, internal displaced people. This is the situation which we met in the camps around the city of Duhok. The adults were occupied by their problems of war, and the children, and usually the families were extended, having more than 8 children per family. They were left neglected, directly or indirectly. What we did in order to help those children in their crisis, we developed SIPCA. What is SIPCA? Crisis Intervention Program for Children and Adolescents. The aim is to prevent post-traumatic psychopathology among those children. It consists of 1 week training for trainers, 2 facilitators train up to 30 trainers. Every 2 trainers train up to 30 group leaders, and every 2 group leaders lead 30 children in 1 hour, single group intervention. The target is children and adolescents in crisis situations. WHO helped us in order to deliver SIPCA to children in the IDP camps. Here inside the mental health house, we made mental health house as a station for training of the professionals and to build up our multidisciplinary teams to provide the children inside the camps with psychosocial help. These are our teams consisting of at least 1 doctor, at least 1 psychologist, and 1 social worker. You see here we have 2 who have yellow clothes. They are the group leaders, and they train those teachers inside the camps to give them certifications as group leaders. And here is one of the group sessions how it looks like. 2 group leaders provide 30 children. One of the group leaders is the leader of the discussion with the children in the dynamic discussion between them, and the other is an observer who is going to record any psychological distress symptoms in order to refer the child to psychiatric assessment. Our pilot project resulted in 22,000 IDP children received SIPCA during February to April 2015. 2,200 of them, that's about 10% of them, needed the psychiatric assessment during the screening in the group intervention. And among the assessed children, 50% of them needed treatment. 2 years follow-up of those children who received SIPCA is showing these results. And I'm invited to Geneva, to the European Association of Child and Adolescent Psychiatry in July 2017 to present 2 years follow-up results. of Sitka. That was what I wanted to tell you about the story shortly, and now we have probably some time for questions.
Thank you very much, Dr. Abdullahi. My comment also about the hypothesis how people, children in Iraq and Kurdistan have less PTSD than other people. I think another thing is in Iraqi people and in Kurdistani people are more resilient population than other people because of their history since more than a decade. They are facing wars and stresses, and the children also see their parents, if they are more stable, also they feel more safe. So the PTSD become less. So they are seeing their parents, if their parents become neurotic and unstable, the children become also more, have more psychological disorders. Thank you.
Thank you very much, Doctor, for this description. Actually, that's correct. The question is how it comes that the society in Kurdistan is resilient. You say that the generations, the Kurdish society in generations has been exposed to traumatic experiences. But we know that if you are experienced as a collective society exposed to re-traumatization of the catastrophes, then most of the society is going to develop PTSD. How it comes then that society in Kurdistan, despite this exposure repeatedly to catastrophes, it is resilient? I think the society has developed survival strategies, and these are, in the start, are strategies, tactical strategies, that is to develop just now. But the collective society in Kurdistan is consisting of extended families, and the clan system is allowing everybody to be involved in everything as I described in the family. So there are functions in the family dynamics that makes the society to survive. Probably it is one of the cultural characteristics of the Kurdistan society.
Any question? Professor Rizal.
Anyway, I think I have an outpost. Yes. I just wanted to follow up on Dr. Abdul Karim's comment. I have my own explanation, my own theory about the resilience of children, of people in general, and probably children included, in Kurdistan. My own personal explanation is that since 1961 until today, Kurdistan went through periods of stresses, no stresses, stresses and no stresses. I think the periods were long enough for people to recover and learn coping strategies and become resilient rather than having complicated trauma after the second stress. This is what I think, my personal explanation for that. I don't know what you think, but I just want to comment another thing not related to this subject. During your talk, you said clinical psychology is lacking in Kurdistan. In fact, I would like you to know that there is a department of clinical psychology at University of Koya. They are graduating undergraduate students, and there are probably 6 to 8 graduates of master's degree in clinical psychology, and there's a nidus of clinical psychology both in Awir and in Soleimani, and they are practicing clinical psychology. So things are not so bad, and they are really evolving. Thank you.
Thank you very much, Dr. Nizar. For the second comment, actually, I am happy to hear about that. I have heard about the clinical psychology department, but actually I have not noticed or been working with those who have been educated there. The master degree provided to the psychologists in Kurdistan, similar to many other problems, they usually get that master in order not to work clinically, unfortunately. So that's a problem. And your theory about the coping strategies in the past periods is very interesting, actually, and it needs to be examined. But I think you are right, because this period when children return with their families, they should directly decline in symptoms. But the PTSD cases remain, despite the good circumstances. You will probably remember I referred one of the girls to you in Arabic, and you treat successfully them. Yeah. So it's not always right, actually. We don't know yet, but we need it to be tested, to be examined.
Dr. Abdullahi should be congratulated on this piece of work. I mean, seeing 32,000 kids is very notable. But that shows something that there is a need to develop child and adolescent psychiatry as a specialty in Kurdistan. I'm part of the Royal College of Psychiatrists of the UK, and we've been working for quite a long time with colleagues in Baghdad to help them establish child psychiatric training. There is a need, but the question might not be for you, Professor Jazar, probably can help. Is there a plan to establish child and adolescent psychiatry as a specialty here? Could people be trained in the specialty?
Thank you very much, Dr. Najat. Actually, it was very good of you, nice of you to direct the question to Dr. Nizar, because he is among the members of the higher medical specialties in Kurdistan. We have tried to make child psychiatry as a separate, independent specialty according to the Swedish model, but still we have not been succeeded. So I thank you very much to introduce this question.
Can I answer?
Chairman?
Can I answer that question?
Answer, Dr. Saif.
Yeah.
Okay. I don't want to go into a lot of details about that, but I've asked in a lot of psychiatrists internationally at different conferences throughout the world. I think I have a lot of this. And there are two approaches for that. One of them is that yes, you can go directly from MBCHD or from the bachelor's degree to child psychiatry, and that's a track, a short track. And then, of course, we can specialize and become an authority like Abdullahi, who we are proud of as a Kurd taking that position. The second opinion is that no, you have to go through adult psychiatry or general psychiatry, and then subspecialize in child psychiatry. At the moment, I think it is about time to think about this second approach, or the Swedish model, but as I said, it's not accepted all over the world. Probably some countries follow that model. Right now, I am not in a position of authority to make any decisions about that thing because, as you know, I'm not in a principal position at the university. So the answer to that question is I cannot answer that.
One last question.
May I have comment to Dr. Nizar? Thank you very much for this invitation. And I think that's the important thing that we cannot answer now. But I think these discussions must be at the level of the academic first, in order to tell the politicians who don't know about that. I can tell you, Dr. Nizar, that our attempt to introduce the Swedish model in the book has succeeded very well. Internationally, it is very good recognized. During September, I was invited to the IACAPA conference in Canada, and I am their ambassador, the child mental ambassador, the IACAPA. So they were very much proud of this system, and every year they publish a report about our activities. You see, we have just now 6 specialists in child and adolescent psychiatry in the book. Many of them, I hope that all of them are here today. And they are going to present their presentations tomorrow. And they are specialists. Every one of them has taken a very important position in the society as well. So they are deciding maker, and they are introducing this model successfully in the society.
Thank you very much. Thank you, Dr. Abdullahi, for your nice presentation and about the discussion. Thank you. you very much.